So, welcome everyone who is joining us for our webinar this evening. Um, this is the Hemophilia Council of California's monthly webinar series. I'm Lynn Kinst, I'm the executive director. And tonight we're going to be talking about Medicaid cuts and how those are going to impact Medi-Cal and healthcare here in California. So, I want to go ahead and again, welcome everyone. We encourage you to say hello and introduce yourself in the chat. We want to quickly thank our sponsors who help make this webinar series possible. We also want to remind everyone that neither the Hemophilia Council nor our speakers this evening are providing legal counsel or medical advice. So just a quick introduction. If you're new to the Hemophilia Council, we are a nonprofit that works in collaboration with four California hemophilia organizations to coordinate the advocacy and access to healthcare work for the bleeding disorders community in California. And we also partner with a lot of other folks that have rare and chronic conditions. So we're going to jump right in. And I'm going to kind of kick us off with a little bit of focus on some of what is going on at the federal level. And then we have David Gonzalez here, who, for those of you who have been on our webinars frequently, you may have seen presentations with his wife, Cher, who is both his business partner and his partner in life. So we're thankful that David could join us this evening. And when we get a little bit further in the presentation, he's going to jump in and help me with some updates related to the California budget and how those things are going to impact Medi-Cal potentially. But I want to start just kind of with some level setting, right? So what is Medicaid? Well, Medicaid is a federal health insurance program that was created back in 1965. Today, we estimate about 70 million people use Medicaid in the United States, and every state has a Medicaid program, but those programs do vary from state to state. And they are funded by a combination of funding from both the federal and the state government. So in California, we call this program Medi-Cal. Now, you also, I'm sure, have heard of Medicare as well, right? Medicare is the program that typically folks access when they age into Social Security, is when folks transition to Medicare. And that is, um, and sometimes it's also, if you qualify for Social Security disability, that might be another way that you would access Medicare. Okay, so what does Medicaid cover? Or who does Medicaid typically cover? So children. Medicaid is a program which is a major source of healthcare for children across the country, especially those that are living below the federal policy poverty level. In California, that accounts for over 50% of the children in the state of California. It also often will cover pregnant women. Coverage is provided to ensure access to prenatal care and delivery services. So even in a lot of states where other adults don't typically qualify for Medicaid, often pregnant women are covered. And then seniors. And this is where it can be a little bit confusing people, right? Because we think of seniors and we think of Medicare instead of Medicaid, but Medicaid also provides a lot of coverage for low-income seniors, in addition to the coverage that they get under Medicare. Sometimes it helps with some of those gaps, and additionally, it's the primary source of like any sort of long-term care funding, outside of whatever private insurance folks might be able to access. And then people with disabilities, those who are unable to work or may not be able to access other forms of insurance. Okay. So specifically in California, who is on Medicaid or like I said, what we would call Medi-Cal here in California? Today, there are about 14.9 million people who are enrolled in Medi-Cal in California. And as I mentioned earlier, it covers more than 50% of all children 17 and under in the state of California. Medi-Cal also covers about 40% of all births in the state of California. So again, a very significant portion of our population who needs prenatal and coverage for birthing services, that would be through Medi-Cal. And in a typical year, about 30% of people with bleeding disorders across the country utilize this Medicaid program to access care. But in California, that number is closer to 50%. And so a very high percentage of our population here in California is accessing coverage because of what they can get through Medi-Cal. And then, as I noted, Medi-Cal provides long-term care for many disabled people and seniors, which is, a very important support for that population that needs it. As I think we all know, it's very expensive otherwise. So I want to touch a little bit on Medi-Cal expansion and kind of what we have, some of the expansion that's taken place in recent years. So under the Affordable Care Act, states had the option to expand Medicaid to quote unquote non-elderly adults with incomes up to 138% of the federal poverty level, and provides up to 90% federal match for that expansion population. So that's a little confusing and maybe a little bit in the weeds, but essentially, you heard what I said earlier that Medicaid is paid for in a combination of state and federal funds. Well, the ratio between how much the state pays and how much the federal government pays varies across different populations of people. So in most cases, it's probably somewhere around a 50-50 split in a lot of cases. But with this expansion population under the ACA, the federal government was seeking to incentivize states to get more people on insurance. And so they increased that match to 90%. And also, just by way of a reference point, we hear like 138% of the federal poverty level, and we might think, oh, wow, that's people who make a lot of money. That is not 138% of the federal policy poverty level is not a lot of money at all. I think for a family of four, off the top of my head, it's like somewhere around $40,000. It's very little annual income, really, even at that 138% level. And then I also just want to note that since 2014, California really robustly has expanded Medi-Cal to various populations that didn't have access before. They were definitely one of the states that under the Affordable Care Act, immediately continued to expand the population, and then has also expanded pretty significantly to cover low-income immigrant communities in California. And that was the most recent expansion, which really only went into effect, I believe it was January of last year, for those populations. And we've found that one of the things we're going to talk about when we get to the state budget, it's been very costly because there is no match from the federal government for that population. So the state budget is bearing the full cost of those recipients of Medi-Cal. Okay, so now we're going to jump in. So that was all kind of trying to give some background for those that really I think we all hear about Medicaid and Medi-Cal and Medicare, but how much of we really understand the details, might be a little more of a question. So that's all kind of by way of background. So now to kind of jump into what is happening, what is being debated. If you are watching the news or spending any time on social media at all, I'm sure that you have probably heard, about some of the debates that are going on in Congress right now and, some of this discussion around cuts. So the Congress is working on what we call the reconciliation bill. The thing that's important about a reconciliation bill in terms of what that is is it is focused on spending. So in order to be included in the reconciliation bill, it has to be something related to federal spending. But the other difference is that these can be um passed by a simple majority. So rather than many provisions which have to pass the Senate with 60 votes, this can pass with a simple majority. And so President Trump has been pushing to have many of his proposals, particularly, excuse me, as it relates to spending, um, to have those put into law through this bill, through this reconciliation bill. The proposal is looking to cut around $880 billion over the next 10 years. So I do want to be clear, that's cost savings that is supposed to be realized over a 10-year period of time, not just a single year. But regardless, that is still a lot of money that needs to be cut from the budget in order for them to reach those goals. So some important, and there's a lot of detail in this bill, a lot of detail about healthcare, a lot of detail about other topics as well. So we're only, because of time, really going to hit on some of the major points of concern and consideration. But it requires states to impose cost sharing for some of the expansion population. So remember, we were talking about under the ACA and sort of during COVID, we had that expansion population. Those are some of the folks that are going to have a cost sharing included. And then it also, and this is somewhat important for California to note, it reduces the expansion match from 90% to 80% to any state who is providing coverage for undocumented individuals or immigrant populations. And so that provision very likely will hit California and reduce, even though the federal government is not paying for those people, essentially what it's doing is reducing the amount of money that the state of California will get from the federal government for other people that are being covered under Medi-Cal. And I'll just note, thanks, Adam. Adam from HFA put in the chat the specific dollar amounts for what 138% of the federal poverty limit is. It's just a little under $22,000 for an individual and a little over $44,000 for a family of four. So not very easy anywhere in this country, I don't think, to live off of that amount of money annually. In California, in particular, there are very few places, and I don't think there's anywhere you could even remotely live off of that. So, okay, and then two additional points in the reconciliation bill that I also want to point out is this new work requirements. So, a minimum of 80 hours a month for some individuals in that 19 to 64 age category. And as of when I did these slides, and I think that this is still correct, the current version of the bill makes that effective January 1 of 2029. So would not go into effect immediately, but we do know that there are members of Congress that are actually pushing for this to go into effect sooner. So, this is still something that is in process being negotiated, and it has been held up in different points along the way. Unfortunately, some of how it's getting held up is actually by people who want the cuts to be larger, not by people who are opposing the cuts. And so that's something to note. And then the other item of concern is that it requires states to conduct eligibility redeterminations at least every 6 months. And so one of the things that um, I want to note is that during COVID, we suspended redeterminations, right? So what that meant was if you were on, for us here in California, if you were on Medi-Cal and You didn't have to annually like refile paperwork with all of your work information and all of this other information. You didn't have to do that every year in order to stay on Medi-Cal. We did not want people losing their coverage during COVID, and so we suspended that redetermination process. And a lot of the like the roles, so to speak, of people who were enrolled in Medicaid across the country definitely increased during that time because people were not falling off for a variety of reasons. When those redeterminations were reestablished, we had a lot of people that lost coverage. And many of them were not people who lost coverage because they were no longer eligible. They lost coverage because of administrative issues. Their address was out of date, and so they didn't receive the information from from their state saying you need to fill out this paperwork. And so they didn't return it, and then they just got disenrolled. Or, they filled out the paperwork inaccurately, and so they got disenrolled. So there's a big concern in that we would see a lot of eligible individuals. So again, not people who like are not eligible and therefore that's why they get taken off because they don't meet the criteria anymore, but rather people who just for administrative reasons don't get sort of dumped off the program. Think about like for those that are on private insurance, maybe through your employer, like what a pain it is every year to like refill out all of that paperwork, et cetera, annually. And imagine if you suddenly had to do that twice a year or four times a year, which the way this is phrased, a state could theoretically, I think, implement it even more frequently than because it says a minimum of every 6 months. And so think about if you had to keep doing that over and over again. And think about particularly populations of people who are sick or may have language barriers. It becomes really burdensome to have to do that paperwork all of the time. Okay, so what does this mean? We're gonna transition over to California. So David, I'm gonna let you jump in here with me, and we're gonna talk a little bit about the current state of the California budget and how that's impacting Medi-Cal.
Okay, great. Thanks, and it's great to join everyone today. It might be good to step back just a little bit to remind us where we're at. So, as you know, in California for a state budget, the governor proposes his budget in January, right? And then we go through these few months, in the interim, and we're waiting for his May revise because the May revise is a really important document. Because basically, the governor looks at his numbers and sees is there better stock market numbers coming in? Are we getting better tax revenues? And they readjust that January plan to reflect those numbers. Now, it's kind of funny. If you look at the January budget, it's not funny. You look at the January budget, it was actually cautiously optimistic. He did note that had a $12 billion shortfall, but then there's sort of this tone that we can tighten some things up and we'll be fine. Barring something crazy like international volatility and stocks trading at wild levels. I mean, it was weird. It's almost like they knew that something like this might be coming up, but they're saying in terms of like this will never happen. Well, both have happened from then until the May revise, and also some additional things that are really impacting our healthcare budget. And we've now started this process. We're now in May. The May revision has been released on the 14th. Now we're doing this process where the subcommittees that are in charge of these subject matters on the healthcare side of things are having hearings on these proposals. I can tell you that there's a lot of cuts involved, and there's a lot of pushback from a lot of folks, from legislators, from constituencies on the healthcare. Because if you look at the budget in total, we're talking about cuts. Almost all of them are on the healthcare side of things. And I think there was some note in a hearing yesterday that this is the first time the Medi-Cal budget has exceeded the education budget. And so it's gotten the attention of folks high in the budget level that this healthcare thing is growing. And, you can see it's a lot of it has to do with this Medi-Cal expansion that Lynn talked about earlier. So unfortunately, it's bad news with some bad news and a little bit of more bad news. The other thing is that, in terms of the federal volatility, we weren't sure how much cuts they're going to be happening, and we anticipate now massive cuts. And as Lynn was mentioning, a lot of our programs like Medi-Cal have a half federal match. I don't think we're going to know those numbers about how much cuts going to happen until maybe June or July. So the timing's awful for California because we have to have our budget passed in mid-June. And so we're going to pass a budget with huge holes of dependency on federal monies. Because remember, this budget is dependent on these federal monies coming in. And so I anticipate we're going to probably pass the budget on time in June, but then likely after that, we're going to have a series of special sessions to address the new things coming out of the federal government. And a lot of these things are going to be discussion will be the cuts. The other thing I'll mention is that something that wasn't anticipated or should have been anticipated is the MCO tax. California's initiated this MCO tax. I was at a doctor's conference last weekend, and we had some federal folks there speaking. And I can tell you the feds consider what California does on the MCO tax basically a type of fraud. So they're very anti what we're doing on the MCO tax. And so even the dependence on those revenues is in question also. So we're kind of getting hit from all sides. Our normal revenues are getting hit, and then also these assistance that we normally get at the federal level is taking a hit. And so as you can see, when we're going to start talking about in the rest of the budget, for the most part, we're talking about cuts. So maybe the next slide. Do I control that, or do you? Is that the next one? Yeah. Okay, so reinstates the medical asset limit test. And if you look at the asset limit test that we used to have a long time ago, those are small numbers, 2,000, 3,000 for a couple. So having just a little bit of money in the account will keep you from eligibility. So that's a disappointment right there. New controls. It's kind of interesting. There was this provision that we passed recently where there was like sort of a continued use coverage. So if you had done a certain medication for 100 days, you wouldn't have to petition to continue having that drug if it was off the formulary. Now, with these proposed changes, you're going to have to actually petition and do a prior authorization if it's not on the formulary. They're going to really be strict on the drugs need to be on the approved formulary that DHS is approved. Sorry, I had trouble with that acronym. All right. And then the other big one is the elimination of the GLP-1 coverage. That's the Ozempic, the weight loss drugs. But if you look at the budget documents, they actually saw a big increase in utilization for these types of drugs. And if you look at the estimates of cost savings for just the elimination of the GLP-1 coverage, they anticipate by 28-29 a savings of about 700 million. And so they obviously are projecting a lot of utilization increase throughout from now until 29 on GLP-1 medications. And so they're trying to nip that in the bud and say, we're not going to cover that benefit.
Yeah, and I just want to kind of bounce off of a couple of those things, David. I want to highlight and sort of emphasize that Medi-Cal asset limit, test, and say that, the real concern there is that why the state eliminated it, I think, was in major part because of how much that contributes to homelessness. Because if you are not allowed to have, say for a couple, more than $3,000 in the bank, like it becomes very difficult to get housing. Excuse me, you have no ability to respond to an emergency situation, right? Because you literally have had to spend down everything in order to have access to your health care. And I do think that there's going to be a lot of pushback on that, but that is very concerning. The utilization management pieces, we've had pretty good access through Medi-Cal, CCS, and GHPP to whatever treatments people needed. That is very concerning. And while while the GLP-1s are not obviously specifically a bleeding disorders related drug, I think what it signals is, the department's and the state's concern about high cost drugs. And, I hope that that doesn't indicate, other more draconian issues down the road. Down the future if our budget continues to be bad. So that's, I think, why we wanted to mention that one in particular.
Yeah, thanks, Lynn. It was interesting, like during these budget hearings this week, so in the Legislative Analyst's Office, for those of you that don't know, that's a nonpartisan group that sits at these budget hearings. And they're sort of like the non-political person in the room. It's just the facts. They're coming just to advise the legislature on these budget proposals. And they had a criticism of a lot of these cuts. And the criticism was basically that what you're doing is you're going to create some inequities based on just when the person became part of the program, whether they didn't pass that test, the asset test. And so there's going to be these different tiers of benefits. And it may be really difficult to administer because Medi-Cal's now going to have to look and see what type of enrollee they have. And there's going to be dependent on what their benefit whole structure looks like. And so there may be some real implementation issues. and a lot of cost associated with having these different tiers. And so, interesting from LAO, that's actually usually in favor of cuts, doing a little bit of a criticism about this approach that the governor had. Yeah, then continuing for the cuts, some more bad news, of course, the freezing the enrollment in full skill Medi-Cal for adults 19 and over for the undocumented population. There's the $100 premium implementation for those that could be a barrier for a lot of folks because we're dealing with some pretty low income individuals. Eliminates the coverage of long term care for that undocumented adult population. Full scope dental benefits as well, and a reduction in payments for the FQHCs at the rural health clinics. So a lot of reductions in the program that they're seeking. Again, there was a lot of pushback by the legislature this week on a lot of these subcommittees, and a lot of the advocates came up, especially on the hospital side, clinics, and just folks that are in the system right now that are going to see these cuts happening to them. And so we'll see where it goes, but it's going to be a pretty tumultuous discussion as they negotiate the details of the budget up until the mid-June release.
Some of the broader impacts, and feel free, like David, bounce off of these and some of the things that you're hearing from folks and some of the, testimony. I mentioned it a little bit, but for the proposals like the more frequent redeterminations and work requirements, we really do have studies that have shown that these add administrative costs to the system, burdens to the patients, and they really don't necessarily end up saving very much money. Like the assumption is, and the argument is that, it's basically like the idea is, we're gonna catch a bunch of people who really shouldn't be getting these services. And that just really isn't the case. I mean, studies show that for the most part, folks that are on these programs are qualified to be on these programs based on the criteria. They definitely need this support in order to access healthcare. And when we add all these burdens to the system, it just ends up disenrolling. And the cost savings is really coming from people who should be accessing these services no longer being able to access them. Um, and then we are also very concerned that this is going to put like hospitals and our providers at risk. There are some hospitals in California, for example, that as much as 80% of their revenue comes from reimbursement of patients that are on Medi-Cal. If that if those Medi-Cal dollars go away, that hospital is not going to be able to keep their doors open. In many other cases, those are kind of the outliers, the ones that are like 75, 80%. They do exist. But even ones that maybe it's 50 or 60%, where are those, how are they going to shift those costs, right? Like, where are they going to get that money? Because they still have to pay their power bill and pay their employees and keep the lights on and do all those things in order to be able to provide healthcare at that facility. And so we have concerns that these changes and these cuts will put at risk some of those providers, particularly in more rural areas that are already being impacted by like a reduction of available healthcare services. David, did you want to add anything to that?
No, maybe just to add that, like, this is an odd year for our clinic partners because they're actually they're under scrutiny for a lot of different approaches. Like, I think there's an MLR requirement that they're looking to put on clinics, and so they're battling, unfortunately, a lot of different fights right now. It's gonna have a bad year for them.
Yeah. Okay, so I want to jump in and talk a little bit about like what we can do, like the advocacy side of this, how we can really advocate on behalf of ourselves and our community and what our concerns are about this. But before I do that, I want to see if there are any questions. It was a lot of information. To be honest, there's a lot more detail that you could go into when you're looking at all of this, but wanted to try to keep it hopefully at a level that everyone can absorb and kind of highlight some of the most important provisions that we are concerned with. But any questions on that? Okay. I don't see any yet, but feel free to, unmute or use the raise your hand feature or put your question in the chat if anything comes to mind as we continue to chat a little bit. So I want to talk about actions that we can take as a community to help sort of reach out. Our stories are so important. And, really, I know that we look at what's happening, particularly at the federal level right now with the budget reconciliation bill and the proposals that are in there are very concerning. Some of the proposals that we heard being floated were much, much worse, believe it or not. So I do think that all of the advocacy, all of the individuals that have been contacting their members of Congress and reaching out and talking about their concerns has already impacted this process and been something that has helped make it not as bad as it could be, right? Like it could be, believe it or not, it could be worse. And so I don't want folks to feel like, oh, this isn't going to do any good or it's not going to help. I do think that we are making an impact. So for the federal issues, the leadership is pushing, and we're anticipating that a vote could come in the House of Representatives as soon as tomorrow, the end of this week. That's their desire is to move this along and get it done before the Memorial Day weekend. And so they are pushing towards that. So continue to reach out to your member of Congress, or specifically the members of the House of Representatives, because they will be ultimately all having to vote on this on the floor. But I do think that as soon as that happens, we're all going to turn our attention to the Senate and really double down on reaching out to the US Senate. I do not believe, and as I've listened to a lot of federal policy experts who have been talking about this, we do not expect this bill will go through the Senate without amendments. There will be changes likely in the Senate, and the margins are much closer in the Senate. We really only need a handful of U.S. senators to not vote according to party lines in order to significantly impact kind of what ends up in this legislation. And so we want to do that. And there's a variety of ways you can do that, right? The probably the biggest impact you can have is go and have an in-person meeting at your member of Congress local office. They have local offices. They shouldn't be super far from you. You can call and request a meeting. But you can also drop off materials. You can also make a phone call. You can also send an email. And we do have, after our April webinar, we shared information about how to go about doing that. And we will be resending that out again with this specific advocacy information to remind everyone, like, how do you reach out to your member of Congress? We can also do that with our local state legislative officials. We can do that particularly as it relates to the budget. I will say that in California, the budget process has become, um, it's very much dictated by the leadership. So there's a handful of very powerful legislators that really decide, um, really sort of decide how this is going to go. And so our organization is reaching out to those leaders with our specific concerns, particularly related to the asset limit test and the changes to utilization management. And then, you can post on social media. We've been sharing a lot of information on social media. So if you're on there, please reshare some of those resources and stay informed. And then I just keep trying to encourage everyone in these times, like, I think that there's a lot that's empowering about being an advocate when we feel overwhelmed by some of the news that we're hearing. I think it really can help us to take an action step and be like, okay, I did something about this thing that's really worrying me. But sometimes we also need to step away and take a little break from it, right? So don't be afraid to like sort of, you know, step away from the media, step away from social media, like take a break, go for a walk, enjoy time with your kids, like take care of yourselves in the midst of all of this because I know that this is causing a lot of people a lot of anxiety and concerns. And then there's many things to be concerned about for many communities right now, right? This may not even be the only issue that is is worrying you. And so take care of yourself in the midst of this. I see there was a question, considering that many bleeding disorders family have with children are undocumented, can they participate in advocacy to talk to congressmen or legislators even if they are undocumented? So, I think how I would answer that is that every family needs to make decisions about what they feel most comfortable with right now, right? Obviously, there are folks that are very worried and, rightly so about efforts that could put them at risk. And so I would want families that are undocumented to be careful about that. But um, I think particularly in California, I think there are a lot of legislators that would be safe legislators to reach out to, where they absolutely could reach out to them because even if they are not, um, currently voting citizens of the United States, they are still people who are living and working and contributing taxes and doing all of those things. And I think many legislators would be happy to hear from them and it would not necessarily be risky. So if a specific family has a question about the legislator in their area and whether or not they feel like that's a safe choice, I'm happy to kind of do that one off with folks in terms of you know, their comfort level in doing that. And then I think, those that are not in that situation certainly can be outspoken advocates on behalf of their friends and family members that find themselves in this very difficult situation. Right. And so I hope that helps answer that question. It is a little tricky, I understand, for those families. Okay, and then just kind of to that, what are we asking for when we go into these meetings or when we're talking to folks? Really, the simple thing is that we are asking them to protect Medicaid for our most vulnerable patients and communities. If you have a story about your own experience with Medi-Cal, that is one of the best things you can share, how that access to care has impacted your or your family members' lives. It's a great story to tell. And even with that, it kind of makes me think your question, I think Laura, that was you who asked that question. If there are community members who don't feel safe sharing their stories, but maybe would feel safe sharing them with us, we can share them with not identifying their names, right? So, like, we could take those stories to legislators and talk about the specifics of this family without telling them the name of the people and where they live, etc. So that might be another way for them to feel like they have an opportunity to tell their story without, but somewhat protected from, the potential risks. Um, so any questions on any of that information in detail? Questions for David about the state budget or the federal issues? Okay.
think we depressed everyone, Lynn.
I know it is kind of, that's why I tried to be like, take care of yourselves, because it is a little, I know it's overwhelming for folks. The one note that I would end on in California that is a positive, something positive that we can think about is, so despite all of the cuts in the state budget and despite what we're facing in the federal government, the proposed budget for CCS, California Children's Services for our kids, has not been touched. And the proposed budget for GHPP, I just see this. I was about to say that, and the question popped into the chat. The Genetically Handicapped Persons Program is also fully funded for this coming year in the proposed budget. I do have, I'm not without concerns that if all of a sudden a bunch of people in the Bleeding Disorders community have to switch to GHPP, and that budget grows, that couldn't create problems down the line. But in the immediate, we do have the option to go to GHPP. And if you're currently a Medi-Cal recipient or you have Medi-Cal plus GHPP and something happens to your Medi-Cal, GHPP could become your only insurance. And so I do think that compared to a lot of the country, we have a more robust safety net. And that's something that we shouldn't forget when we start to get anxious about kind of what we see happening.
Yeah, I saw a question from Ryan.
Yep.
When do we think the budget bill will really be final, and will there be some details to iron out before July 1st? It's great questions, Ryan, as usual. Ryan, you've been around for a while. Like back in the day, we used to have these long budget sessions that the budgets were overdue and they weren't passed. Then all of a sudden, we passed this law that says if you don't pass the budget on time, all the budgets were on time. Is that if you don't, then you don't get your salary. So once that salary thing was put in place, all of our budgets have been in place on time. So I think June 15th is the last day to pass the budget. I think we'll pass it on time, but it's going to be, again, a little bit of a paper budget because there's some big holes in it in terms of our funding because if the feds do these big decreases, we're talking about billions in reductions that California's going to have to make up for in some way. So I think there's going to be special sessions. A little bird told me we're likely to have special sessions after the budget's passed. So expect something on time, June 15th, so everyone gets paid at the legislature. But then there's going to be some follow up after that when we get the bad news from the feds.
So does that allow like some additional opportunities for like advocacy in those special sessions? Like I would think it would.
Ryan, that's a good point. I think it actually absolutely does because frankly, I think those special sessions are going to be tough because that's when we're going to know like how much money is coming off the table from the federal government, and all indications are it's going to be a lot. And so that will be a sort of an active time during those special sessions, which will be sometime between June 15th and December 15th. But I'm sure there's going to be lots of pushing about don't cut us during those times.
I'm just kind of scrolling through the chat. I know we're already running short on time here. Adam, did you want to say that comment out loud? I would love for you to share what you put in the chat, or I can read it for you.
Yeah. So I just had dropped it in the chat, but I've mentioned this to a few other people that I've talked with in the past few months. This really is like if you think of the Dr. Seuss story, Horton Hears a Who, it's very much that type of a situation. Every single voice counts, even if you think that you're just one voice or just one person. Um, there was an advocate in Illinois who met with his representative on a weekend. It was like a Saturday. He scheduled a meeting in the district office in Illinois, and that representative then read that story on the House floor a few days later and put it into public record. So, sometimes things that happen in Washington can feel slow. Sometimes it feels like maybe we're just one out of, a multitude of people who are all shouting or we get drowned out, but it really does matter. And if everyone thinks to themselves, I can speak up, I can make a difference, then that's all those people together, even if they don't know each other, who are all thinking, I can speak up and I can make a difference. And it does make a difference. So I just want to mention that always, feel like you do matter. We have a participatory government for a reason, and I think that do your best to feel confident in yourself, and that people do hear you if you want to tell your story and speak up.
Yeah, and I would just emphasize that. Please do. And then this wasn't related to the budget or Medicaid, but I also heard a story related to the all co-pays counts legislation in North Dakota. There was a legislator who had been very opposed for a couple of years as they were working on this issue, and a constituent went and met with them and changed this legislator's mind. And she was a very influential legislator. And then she invited that constituent to sit on the floor with her as she spoke in support of their bill. And it ended up, passing and going to the governor and getting signed into law in North Dakota. And it was truly a situation where this constituent was able to get this meeting as a constituent and change this person's mind. So it is possible to have an impact. And on this issue in particular, as we think about Medicaid and all of these things, we our voices are joining with lots of other rare disease and chronic disease and disability awareness groups that are also speaking up on this issue. So we are not, we're not alone in this. So there was one last question here about online resources to keep up to date with the current budgets and changes. Like, if you really want to kind of get into it and study the policy stuff, the resource that I would recommend on the federal side for what's happening in Congress is the Kaiser Family Foundation. Their website has a lot of really excellent, and they're updating it like daily, multiple times a day on what's happening with the reconciliation bill and how that is affecting, how that's going to impact different states. And so we can try to find it and put it in the chat, but you could also just Google Kaiser Family Foundation, and that would be a great resource. I'm trying to think for the state of California, um, with a quick, I mean, you certainly can go and try to track stuff on legislative websites. Cal Matters might be a good one that does some things on the state budget, and the California Healthcare Foundation tends to track a lot of things related to Medi-Cal. But then also, I would say we're trying to really, put out as many updates as possible. And so if you are like on social media, for example, if you follow HCC, we'll definitely continue to post updates. Um, and BDF, HFA, we're all posting updates. So hopefully that helps. And yeah, perfect. Thank you, Adam. Adam put the Kaiser Family Foundation link in the chat as well. So I want to go ahead and make sure to thank our sponsors again, and thank you guys all for joining us. I will stay on for a couple more minutes if anyone has any last questions that they didn't get a chance to ask. But thank you guys all so much for joining us. We are going to send follow-up information with those advocacy resources out. Encourage you to please reach out to your legislators. Contact us if you have questions about how to do that, or let us know how it goes. We'd love to hear stories of when you do reach out and, what your experience was. And we really thank you all for joining us. I want to give Mariana a shout out. She's with the CF community and she joined us tonight. So yeah, like I was saying, there are lots of us from lots of different communities here together to fight these battles and help one another. So thanks for joining us this evening, and thank you, David, for joining us as well.
Thank you. It was a pleasure.